Hi, Nargiza, are you there?
Hi, John. Yes. Could you make me co-host, please, so that I can?
No,
You cannot? Okay.
I did. I made you already.
Okay. Yes. Done. Thank you, John. Thank you. Just a
Okay.
second. I have to.
Okay.
Gallery, speaker, hide self. How to blurry background? John, could you help me, please?
Yeah, go to the
View?
go to the menu next to the camera. You see the icon in the left
No,
lower corner.
I see start video, participants, chat, share screen, record, captions, whiteboard.
No. You see the microphone, the far left at the bottom?
Yes,
Okay, you see the camera?
yes.
Okay, next to the camera, you have a little menu.
Blur my background. Just a second. Let
Yeah.
me see. Now, can you
So
see me?
there you go.
Okay, nice. Just a
Well, let
second.
me make that pin off. There you go. You're still a
Thank you.
California. You're still a California girl.
No, yeah, I am.
Do you have your surfboard with you?
Yes, I do.
Okay, so you have the first speaker is Andre. How you doing? Andre's
Dr. Andrei Dubovoi today has emergency case. Okay, so he will join us for 5-10 minutes. Then he has to go to operation room.
okay.
Okay, this time it happened, unfortunately, but
Okay. Well, work comes first.
first, hello everyone, myself Ranjish Barman from First Moscow State Medical University. Hello,
We're
Ranjish,
not
how are
started.
you?
Haven't started yet, Nargiza.
How are you doing?
We are doing
Hello.
good. Where are you from? Originally from India?
Oh yes, I'm originally from India.
Which state?
Northeast Assam.
Assam. Oh, Assam. Oh, great. I was in Siliguri, but haven't reached Assam yet.
Okay. It's like only like 300 to 400 kilometers from that place to my hometown.
Great. So it's great that you joined us.
Even
Is it
in
your first time?
it's my first time. Yes, it's my first time joining.
Okay, nice. So you can share your Gmail address and contacts, and I will keep sending you webinars.
Yeah. Sure. I'm about to do it now.
Okay, great.
So
Yeah,
thank
you
you
can
so much.
you can join the YouTube channel.
YouTube channel or yes.
Can I know the name of the channel?
Yeah, let me get the address of the channel, and that way you get notices of the webcasts that are recorded, that are live. Okay, I'm going to put it in the chat. Okay. Okay.
Hey, John, it's Mario here.
Hey, how
Professor
you?
Dr.
Professor
Mario, good
Spallone is
morning.
going to join soon. So I told him that if he's fast enough, we will upgrade him as panelist so he can comment on the presentation as well.
Sorry, who is going to join?
Aldo Spallone.
Great. Okay, done. Of
Thank you,
course.
Nargile. Thank you
I
so
will
much.
make a panelist as soon as he joins. Okay.
Thank you.
Okay.
Yeah, Aldo's a part-time resident of Florida, right?
Just a second. Okay. Dr. Samarin, good afternoon. Welcome. Dr. Anton, good afternoon. Welcome. Just a second.
Okay, I put the link on the chat to join the YouTube channel of, try that, Ragnish. You see the address there?
Let me check.
Make sure you get in there.
Yeah, sir.
Hi, John. Hi, Nargiza. How are you?
Hey, how you?
Hi.
Welcome.
We are good. Welcome.
John, this link our translation.
Yes.
Oh, okay.
Your background, is that your background okay, or is it backwards? Because you can reverse it. You know how it's a mirror image, Anton? I think your background was backwards. Or maybe in Russian. Russian looks like backwards English.
Hello, John. Hello, Nargiza.
Hello, Doctor. Hello, Andre. How are you?
I'm fine, thanks. I will introduce Dr. Alex Samarin, and then I should go to OR.
Oh yeah, that's Nargiz was saying. So thanks coming in anyways, but work comes first.
Okay, Alexei, hello.
Okay, see you next week.
Are you
Next
ready?
time.
Yeah.
Okay, great.
Hi, Alex. I'm Dr. John Bennett of Neurosurgical TV. Alex, have you met Nargiza? Alex, Nargiza, could you please introduce yourself to Alex?
Just a second.
Okay. Ragnish, did you join the YouTube channel?
Yes, Professor, I joined us now. Yes.
Okay, all right.
Yes,
Well,
sir.
do it when you can.
Yeah, I joined it.
And Ahmad's here from Afghanistan. We start in about 2 minutes. Do you have the first presenter, Nargiza?
John, give me 2 minutes, okay? I just have few things to do.
Okay.
We will present one by one. So first will be Dr. Samarin, then will be Dr. Rishikesh, and the third one will be Dr. Emrah.
Okay, you run the show. You run it. I turn it over to you.
Yes.
And
So
you determine it.
2 minutes. Mhm.
Okay.
Andrei Vladimirovich, how are you?
Thanks. I'm fine, Anton. Happy.
Are you in Moscow
to
now?
see you. 1 second, please.
Oh,
Nargiza's ready for battle, but first she's got to turn on her microphone.
Yes, John, we are ready. So
Yeah, you ready? Okay. Okay, 10, 9. Okay, let me make sure everything's okay. Okay, you ready, Nargiza?
yes, ready.
Okay, 10, 9, 8, 7, 6, 5. Is it on now? Let me make sure it's records. Hold on, they changed the interface of this darn thing. Oh, they changed the interface. Oh, okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We have another in the series of Russia Neurosurgery Grand Rounds, and we have Nargiza Sartova, MD from Uzbekistan. And she's moderating. She's going to run the show. Hi, Nargiza. What are you
Uh,
laughing at?
Hello, John. Hello, everyone. It's a nice day today. Little bit sunny and not sunny in Turkey. So today is our 13th webinar on Russian neurosurgery grant rounds. We are hosting a second skull-based session webinar. And today we are going to have 3 speakers. But first, let me introduce my colleague and good friend, Dr. Anton Ivanov from Siberia, Novosibirsk Federal Neurosurgical Center. Anton will be hosting the webinar and will introduce our moderators. Welcome, Anton.
I'm glad to welcome everyone to our webinar. Today we have 2 moderators. First moderator is my friend Mario Ganau. I remind that Dr. Ganau is consultant neurosurgeon of Oxford and Spine University Surgeon Hospitals, United Kingdom. Mario, how are you?
Thank you very much, Anton. It's a pleasure to be here with you.
And Dr. Andrei Dubovoy, leading neurosurgeon in head and neck department, Ilinskaya Hospital, Moscow, Russia. Andrei Vladimirovich has an emergency operation today. However, he will be with us for some time. Andrei Vladimirovich, how are you?
Thanks, Anton. Happy to see you.
Okay. Now we return to our speakers. First speakers, Alexey Samarin, consultant neurosurgeon, Ilinskaya Hospital, Moscow, Russia. Dr. Alexey will talk about the lateral skull-based approach in children.
Hello, everyone. Nice to meet you. Let me share my presentation. Okay.
Yes, we are able to see you.
Okay.
You are audible. You are welcome.
Okay, thank you. I'm very glad to see you, and I very appreciate for invitation to this meeting. And I want to share my most experience in lateral skull-based surgery in children. When we talked about lateral skull base, we know that one of the core structure of the skull base in this region is the Peters bone. Also, we have rather complex surrounding structure like neurovascular matrix of the brain, venous sinuses, structures of craniocervical junction, clivus, cisterns of the bases. And actually, in children practice, the pathology features determine the surgical strategy. Of course, one of the most important factors is the localization of the lesion. Its involvement of the vital structures such as vessels, nerves, and brain structures also. And biological features of the tumor is the important factor too. There are some papers in the literature that describes the features of pediatric skull-based surgery and anatomical features, but I will not stop it. Here we can see some of the pathologies that you can meet in pediatric population, skull-based pathologies. When we talked about approaches to this region, we can use different microscopic or endoscopic or combination of
You are muted, Dr. Alexey. We are not able to hear you.
Yeah,
I'll write him via
Uh-huh.
WhatsApp.
yeah, I'm getting another voice. I don't know what's going on. Okay, are you unmuted?
Are you hear me?
Yes, yes,
Yeah,
yes.
now
We can
hear
hear
you.
you now. Yes.
Okay. When we're choosing the approach to the structures of lateral skull base or surrounding structures, we have to think about several important things. First of all, the biological nature of the lesion that we deal with. Of course, we have to think about the common treatment strategy that we discuss with our oncologists and radiotherapists for choosing the optimal treatment strategy, including the surgery, radiotherapy, or chemotherapy, or combination of these options. And this strategy determine the goal of surgery. It could be only biopsy. It can be a CT reduction or gross total resection as an option of local control of the tumor. Of course, individual patient anatomy and previous morbidity also play important role in the choosing the approach. And we have actually in almost all time we have some have to compare some different approaches and choose the optimal. I start from well-known and fast and safety approach that you all know about. Rather sigmoid approach that gives you a good exposure of lateral compartment of posterior fossa. You can control anatomy and the lesion by this approach very well when it's located in this region. Here some clinical examples where I used the RETROSIG approach and it was rather effective and safely approach in such situations. As for skull-based lesions, where we can use this approach, I would like to show this example with lesion that located in posterior part of internal cuscus channel, posterior part of Petrus bone, and you can reach this lesion by retrosigmoid approach well. But the one important thing that you have to think about and to remember about is the closure of defect that exists after the lesion removal. I usually use the parts of muscles or fascias and different gymnatic agents. The next situations that you can meet in pediatric patients, there are lesions of the Petrus bone apex. There could be different lesions, as you can see here. the same rather similar radiological picture, but there are different diagnoses, different prognoses for all these children. And in these cases, when we decide to perform biopsy, first of all, I used actually standard middle fossa, or I call such approaches Kawase-like. One of the main things when you perform the Kawase-like or middle fossa approach or Kawase classical approach is the dissection of GSPN for prevention the seventh nerve palsy after surgery and trauma of geniculate ganglion. Here you can see the structure that must be dissected during this approach. When we have a clear radiological picture, like in this situation, and to understand that we deal with benign tumor like this geniculate ganglion schwannoma, and we can use combination of approaches, because this lesion expands to tympanic cavity. We performed combined middle fossa approach for reaching the intracranial part of the tumor, and transmeatal endoscopic approach for reaching the intertympanic cavity, intertympanic part of the tumor. After resection of the tumor, you can see the defect of Peters apex that created by tumor itself, and carotid artery, Peters part of the carotid artery in the deep of the wound. And transmeatal endoscopic approach can give you a good view for the tympanic cavity part, for revision of it, for removing the tumor, and for expecting the closure of the defect. Here we used myofascial temporal flap for closing the middle fossa defect. Post-op control after 6 months. In more complicated cases, we can use more complex approaches, such as combined trans-Peters approach. Here you can see the cadaver dissection from Takanori Fukushima atlas and intraoperative view after performing this approach. Here's the example of using such way. This is the small child girl with recurrent remnants of anaplastic ependymoma that expands to contralateral right cerebral pontine angle, which involves basilar artery and carotid arteries. Intraoperative photos that shows structures that we can see during the surgery during this approach. Sigmoid sinus in the lab. You don't need actually to drill lab in all cases, because standard lateral labyrinth approach is enough in most cases in these situations. You can see the intracranial structures: dorsum cell, clivus, cranial nerves, vessels. But the key step of this approach is the cutting of the tentorium, because it gives you the opportunity to mobilize the sigmoid and transverse sinuses that can give you more exposure, more angles of attack, and more space for your intracranial work. It's photos with more magnifications. Here you can see the 6th nerve that goes to the Darrell's channel in the Peter's bone. Compartment of internal acousticus channel, 708 nerves, basilar artery, structures of brainstem after moving the tumor. In high magnifications, you can see the good view of vascular structures. I would like to show you some short video that shows the steps of intracranial part of the work. You can see the tumor. You can see the 6th nerve, contralateral. This was left-sided combined petrosal approach, and here you can see the arteries, basilar artery, tumor, internal acousticus channel here, and now we will see the 7th and 8th nerves. And we can precisely dissect the tumor from these structures, from this side, and remove the tumor without damaging the vascular and neural structures. This is the steps of moving tumor. 6th nerve going through the tissue. We can precisely dissect it from the tumor structures. Okay. Postoperative control that reveal no evidence of remnants tumor, and CT that shows the volume of Petrus bone and mastoid defect. Similar situation with child of 8 months. He had a very aggressive embryonal tumor, rhabdoid, and when we discussed this situation with our oncologists, they asked me to resect this tumor in maximum volume. That's why in this situation I choose the same combined transpetters approach, and it gave me opportunity to perform the subtotal resection of the tumor, and after 1 week the child starts his adjuvant chemotherapy. The next group of approaches, craniotheorical approaches, phalateral, lead, anterolateral approaches that you can use in different situations according to the lesion that you have to do. Clinical example: this is 6-year-old boy with rhabdoid tumor of craniotheorical junction with intracranial extension and with compression of the brainstem. And our goal was to remove the intracranial component, and that's why I used bilateral approach, retrocondylar variant, without resection in the condyles. And as you can see, this approach can give you a good view of the neurovascular structures of the ventrolateral near the brainstem. Caudal nerves go into jugular foramen arteries, vertebral artery. It's V4 segment 11th nerve, and you can manipulate between these structures rather safely because you have a good visual control. You have a good enough space for manipulation. This another view from the side. Okay, and of course, sometimes you can meet the situations where you have to, where you have to combine different types of approaches. For example, transpetrosal combined and bilateral approach. The situation like this. This is the recurrent anaplastic ependymoma in children with who received before this surgery and radio therapy. And the goal of the surgery in such cases is to achieve maximal resection rate. That's why sometimes we can use more aggressive approaches for these situations to try to achieve this goal. Here we do the combined transpedros and bilateral approach, and achieved subtotal resection, and it allowed to perform the second step, reirradiation of the tumor, and gives more good oncological prognosis for this child. Of course, you can meet also the situations where you have to perform maximal aggressive surgery, like total pedrosectomy with different resections of dura, different structures of the middle and posterior fossa. Like in this situation, it is adolescent boy with recurrent with relapse of angiosarcoma after several lines of chemotherapy, after 5 resections in different volume. And there I performed the gross total pedrosectomy. Here you can see the line of skin incision, and this the common view of the operative wound after reconstruction, after removing of the Peters bone, and after reconstructions of the dura of posterior and middle cranial fossas by fascial allograft that covered the jugular foramen compartment and C7 and C6 segments of the carotid artery. Postoperative control CT scans that shows the volume of resection Petrus bone, and MRI also. Okay, I showed some situations where we have or we may use some aggressive skull-based approaches in children despite their age. We of course have to think about different advantages and disadvantages of these approaches. Obviously, the complexity is one of the disadvantages of these approaches because it takes more time. It increases the risks of intraoperative and postoperative complications such as CSF leakage after surgery and risks of postoperative infections. But if we deal with the specific situations where we have to achieve a good rate of resection, and it could improve oncological prognosis of the child, we may use such aggressive skull-based approaches, but we have also always remember one thing, that one of the key steps of this surgery is the closure of the wound, properly and careful closure that allows us to decrease the risk of postoperative complications, because often this child have to start their adjuvant therapy in a short time after surgery. Sometimes we started radiotherapy after 2 weeks of after surgery, chemotherapy in 1 or 2 weeks after surgery. That's why closure of the wound is one of the most important steps of this surgery, and you can use different grafts, fascia lata, fat, myofascial grafts, artificial components. And one of the main advantage of such approaches, in my opinion, is high resolution. I mean that it can give you better exposure of the tumor and surrounding structures. It can give you more angles of attack for the tumor, and it can give you more space for intracranial step that decreases the risks of damage in vital structures. In the end of my presentation, I would like to share with you the words that I saw in one of the James Liu presentations. So thank you very much for your attention, for listening to me. It was really a pleasure for me to meet you here.
Thank you so very much, Alexei. Excellent presentation. And I think I can open the floor to some comments. Professor Spallone, do you have any comment on this presentation?
Good
Cannot hear.
afternoon, Professor Spallone. We are ready to get your comments. Also, let me please introduce our one more moderator, Dr. Takashi Kon from Japan. he joined us.
Hello,
Thank
can
you.
you hear me?
Yes, we can hear you.
Okay,
Good afternoon.
okay. Thank you, Mario, for giving this opportunity. Actually, once again, thank you very much, John. The problem is that you call me on my Italian phone and I see it very seldom. I will be very pleased now to contact you regularly. This is a very important initiative in this particular moment. Yes, I followed 80% of your presentation, colleague. I didn't know that you were working in Moscow with such a large experience, since it is actually, how to say, less in fashion than before. I made a presentation on a philosophy of the traditional scalp surgery a week ago, and my idea is that it has still some place in the neurosurgery practice. As you said properly, it requires a lot of training, a lot of dedication, and obviously it needs a relevant experience, since you have to be able to deal properly with the problems that you create yourself by destroying the natural barriers between the intracranial content and the rest of the body, while you have to destroy them to access the tumors. I must add even one comment that I was reluctant myself to consider those difficult approaches for almost hopeless tumors like ependymoma, but I did myself a case. An ependymoma in this location has the characteristics to behave like a meningioma, is resectable, is dissectable for the surrounding structure, and it gives good base, good theoretical base to your choice. You described a very aggressive combined approach, which combined the anterior and posterior petrosal approach. Sometimes the posterior petrosal approach is the so-called pre-sigmoid with the extreme lateral. There are cases when this is needed because those kind of approach gives enough space, the due space to the surgeon to work properly. I know I did understand how you work. When I had to perform those operations, which can take 24 hours, I was used to divide them in 2 steps rather than 2 teams, because my idea, my experience was always that you have your own idea of the geometry. And if somebody makes the opening, some other else makes the work, the geometry, the ideal geometry cannot be the same. So I saw marvelous demonstration. Those cases may be, I have to say, may raise reservation, but I agree fully with your strategical ideas. And once again, this gives a strength to the fact that traditional skull-based surgery, I mean lateral skull-based surgery, the most difficult one, must not be abandoned, even in the area of mini-invasive endoscopic assisted or fully endoscopic skull-based neurosurgery. Thank you once again.
Thank you. Thank you.
Thank you very much. Thank you very much, Professor Spallone. If we have any other comments, I'm happy to give the mic to whoever else might be interested in commenting. Otherwise, we can move to the next speaker. Before we do so, I just wanted to say, obviously, those cases, particularly in pediatric population, might very well require, unfortunately, radiation treatment. These at times is administered even before surgery, or is administered in the context of redo surgery. So the surgical strategy might be, slightly be affected by the quality of blood supply to the flap and obviously the risk of wound adhesions in case of flaps that have been already treated with either conventional or stereotactic radiotherapy, or more recently radiosurgery. I don't think there are any other comments so far. So
We have one question, Dr. Mario,
yeah.
from Abdusami Porsaif. What
Yes.
difficulties have you encountered during surgical access in patients who have previously received radiotherapy?
Okay, yes.
Yeah.
So Alexei, do you want to comment on the issues related to radiation therapy?
Actually, when the patient had previous radiotherapy, we can meet during the second surgery very hard glial and arachnoidal scars that always do our work more harder, actually. And sometimes you have to cut them millimeter by millimeter, and you don't understand sometimes where the vessels, for example, vertebral artery, if that scars are so hard. But it takes much time, and of course the operation could could extend 7, 9, 11 hours. But it's it's a specific situation where there was when there was the previous treatment, surgery and radiotherapy. It's the main problem that I had to deal with during these operations.
For sure. Redo surgery are always the most challenging ones, and adhesions increase the risk of vascular injury, iatrogenic vascular injury, particularly if the vessels are encased into the recurrent tumor, or even cranial nerve palsy if it is difficult to dissect and create a good cleavage plane. And obviously this is always the case in the primary surgery, might not be the case in the redo. But that's the nature of the business, and pediatric surgery, increases the level of complexity because of what is at stakes. So okay, thank you very much, Alexei. Thank you very much. I will now go ahead with the next speaker, Professor Sarkar. He's a senior consultant neurosurgeon from Apollo Hospitals in Chennai. It's a great pleasure for me to introduce him. I visited the Chennai hospitals, Apollo Chennai's hospitals in March last year during my trip on India, and it's a excellent place. I had the opportunity to operate there for a few days with Professor Sajan Hedge. Is one of the best spine surgeon in the area. Professor Sarkar is a consultant at the Cancer Hospital. It's a brand new facility where all patients with neuro-oncological problems are treated, and they have an excellent infrastructure with availability of neuro-oncologist, specialist in radiation therapy, and so they can offer in-hospital pathways that are second to none. So world-class healthcare. Professor Sarkar, are you ready to share your screen?
Yeah, thank you very much. Thank you very much, Dr. Mario, for that kind introduction. Just let me start with sharing the screen.
Yes.
Yeah, is
Yes,
it
sir.
on? Okay, just let me. Yeah, is that clear?
Yes, that's
Yes, we
perfect.
can see you and hear you.
Right.
sir.
Right. Good afternoon, everyone. And I'm first of all, I'm amazed by Dr. Mario's thorough knowledge about Chennai and Apollo hospitals in particular. I'm pleasantly surprised, and I do not have words of gratitude right now towards him that he already knows so much about our place of work. I'm sure that most of our people would not know what he's saying here right now. So I really thank you for the kind introduction, and nice to see you, Nargisa, and thank you for the kind invite, and happy to see
Thank you,
everyone
sir.
here. Um, there was a brilliant presentation by Dr. Alexi, and I know skull base is a very challenging area. And from time, no, it's not only the time, it's the effort, concentration, the team effort, everything plays a huge role in performing a successful surgery. And here at Apollo, with my group, we are trying to individualize these approaches and trying to see which skull-based surgeries, which skull-based tumors we can perform in a minimally invasive fashion. And somehow we have gathered our experience over the last few years. And of late, we have been doing keyhole mini supraorbital approaches for anterior skull-based lesions. And today's talk is going to be focused on anterior skull-based lesions. So this is my group called the Da Vinci's Neurosurgical Associates at Apollo, and I think all of them have joined with me in this presentation. This is Chennai, and that is the world's second longest beach, Marina Beach, and this is our hospital. Everybody is welcome to visit our center, preferably in the month of winters, not now because the temperature is hovering around 40 or so. Going back to the business, today's talk is on anterior skull-based approaches. And as we know that there are many approaches described to reach anterior skull base and various pathologies, starting laterally from the frontolateral approaches down to subfrontal, and then midline skull base, cranial and endoscopic approaches, and coming midline again in front from anterior hintersphincteric approach. Now, one can debate about the positives and negatives of these approach, and of late, depending on our experience and our set of patients with skill sets and other things available to us, we develop our own perspective. And from our perspective, we think that our approach is the best, and rest of the other approaches are not that great. But I think the truth somewhere lies in between. The truth is this, that whatever said and done, whatever approach we choose, I think it should do two purposes. And the purpose is basically balancing act. The balancing act between reaching a primary objective, that is either to remove a lesion or a clip aneurysm, versus reducing the approach-related morbidity, time spent in the OR, and post-operative cerebral edema, traumatic injuries to the brain. So it's a quite fine balancing act, and the judicious approach is the one which balances it all together. And it depends on many variables for this anterior skull-based lesions to see which approach works the best. It depends on the nature of the tumor, how large that is, what's the size of the tumor, how closely it is related to important neurovascular structure, how adherent they are to these structures, how is the surgical training, and how is the skills of the surgeon, and also finally the patient, what patient finally wants. These are the some of the variables which determine a skull-based approach, which can be called ideal. But today's topic, I will mainly discuss our experience with mini supraorbital approach and how we have expanded this to include various other pathology also. And I will discuss this presentation is various subheadings. As we know, the keyhole approach has been there for a few decades now, and basically it involves approaching an area via a small opening, which enables us to do two things, which I called as 2A's. One is to assess the area, assess the anatomy, assess the comprehensive relationship between neurovascular structures, the tumors, and other important structure. And also at the same time, it gives us ability to access this and maneuver around these tumors safely so that minimal collateral damage happens to these blood vessels. So these two things, accessibility and accessibility, is very important. So schematically speaking, if you have to reach a particular area of the brain, one does not need to do a hugely large opening exposing a large portion of the brain. One can manipulate, one can maneuver the table, one can maneuver the microscope, one can use the endoscope to look around, peep around, and to assess and maneuver very safely, thereby avoiding major collateral damage to the brain and the nervous structures around. I have dabbled in keyhole brain surgery, mini supraorbital corridor via mainly two approaches, either going through transbro, which I call traditional, and off late we have been doing transpalpebral or going through the eyelid. And there has been an evolution in my practice on slowly moving on from the transbro to the trans eyelid. The problem with transbro approach is that though it is cosmetically okay, but in some patient it leaves with alopecia, which is not good to look at. It causes puckering. And there are few patients which described in literature also, they can develop frontalis weakness leading to bro asymmetry, as you can see in this lady who underwent a transbro procedure. So over the last 6-7 years, I've started adopting in selected cases transpalpebral or trans eyelid surgery. The theoretical benefit is that apart from being cosmetically relevant, the relationship with the facial nerve, the frontal fibers of the facial nerves, it is far away compared to the traditional transbro approach. You can see the difference. The frontal fibers come like that. If you make an incision for two lateral in the transbro, there's always chance of damaging this. Staying low in the eyelid, somehow you are staying away, and then the chances of having damage due to the frontalis weakness is less. So trans eyelid window is essentially making a corridor into the eyelid and reaching the anterior skull base lesion. Schematically, if you see, that idea is not to disturb this orbital septum, staying above the plane of orbital septum and levator palpebral superioris, so there is no mechanical ptosis, and you are cutting only a portion of the orbital septum and getting down into bone, as you can see in this cartoon. So it gives a direct window to this skull base, and it does not involve any significant or big opening in the cranium. This is again a cadaveric specimen to show you that if you do a transbrow incision, the chances of damaging facial nerve is higher compared to transpalpebral approach. Both the incisions, however, give a panoramic view to the anterior skull base. And basically the exposure is between the 5th and 7th, not in the posterior fossa, but between the supraorbital nerve which is medial and lateral to the frontalis nerves and fibers of the facial nerve laterally. And a small mini orbitotomy, supraorbital craniotomy is done, measuring not more than 3, sometimes 2.5 centimeters, and gives you a very panoramic view of the anterior skull base right from the opposite side optic nerve down to ipsilateral MC bifurcation up to proximal portion of the M2 result. Such a wide and beautiful exposure one gets. And by extending this approach, one can definitely go beyond it also, which I'll explain to you a few cases. So this is the standard area of exposure one can get via this keyhole mini supraorbital approach. You can see to the contralateral side along the fox down to the glandular process and to the sphenoid wing. The very large exposure gets. So which are the tumors which are suitable for this mini supraorbital approaches? Since we are dealing with anterior skull base, of course, these tumors or any pathology located in the anterior cranial fossa floor is suitable. We have operated meningiomas, glioma, and variety of pathologies, including unruptured aneurysms with favorable anatomy. Previously, our inclusion criteria was not to involve any tumor with significant brain swelling or edema, and to have size less than 2.5 centimeters. But both these things were challenging, as I'll show in our few cases. If the tumor is stuck to the vessels, mainly ACOM and other vessels, then it might become difficult. And some difficult aneurysms which are ruptured and with difficult projections are not suitable for this approach. For the eyelid approach, we used to take help of ophthalmologist or oculoplastic surgeon initially, but now we do it independently. We have to keep in mind with history of keloids or any eyelid infection, which could form a problem for the patients with trans eyelid approach. Large frontal sinus is a relative approach because nowadays we are using bone cement and filling up and obliterating the frontal sinus, which has led to significant reduction in any morbidity due to frontal sinus problems. Going to a case, this is a patient with a clinoidal meningioma, pretty large in size, not too small, not too huge, but somewhere in between, but displacing the middle cerebral artery. This is a 45-year-old patient who presented with seizures, headache, and she was losing her vision in the left eye. That's her MRI scan. That shows that's the enhancing lesions based on clinoidal with MC artery, which is completely displaced. And that is the coronal projection of the MRI scan. Again, relatively a good plane with the surrounding brain and displacing the neurovascular structures posteriorly and inferiorly. So this case is a suitable approach, which gives you a direct approach to the origin of this tumor, to the attachment where the tumor arises, and it helps us to devascularize this tumor initially itself. We plan our fascicular craniotomy, the height of which we calculate depending on the preoperative scan. Usually about 2 centimeters is enough. Head positioning is important. The idea is to rotate the head contralaterally to the other side and to have a retroflexion of the head, so the frontal lobe falls away, and that gives us a very nice exposure without any significant retraction to the anterior skull base area. It's important to rotate this head depending on the location of the tumor. If the tumor is olfactory situated more anteriorly, then one has to rotate the head some more to allow us great visualization. However, if it's a tuberculum cell meningioma, you don't need to turn the head significantly. About 20 to 30 degrees is enough. So we position the patient in neutral with head turned to a 20 to 30 with head retroflexed. You keep throat packs in place because if there's a frontal sinus, there could always be an element of blood leaking into the posterior pharyngeal wall. Initial cases, we used to put lumbar drains, but of late, if we think that the tumor is not significantly large enough, or there is no significant brain swelling around, and we can access the sylvian region very quickly, then we do not put lumbar drain. We always keep lateral aspect of the thigh prepped because it's very, very imperative and important to have a very good dural closure. Sometimes in elderly patients, the dura is not that great. So closing it becomes very difficult. So we take some fascia and the muscle and the fat from the thigh and we put it over there. We use low profile instruments and sometimes use endoscope, as we see in the coming cases. And definitely a thorough, proper closure is done. So this is a video which I would like to show it to you. This is on the left side, same patient which I showed you, clinoidal meningioma. This is the incision that is being made on the eyelid. Again, the idea is not to get beyond the orbital septum and stay above it. And slowly the plane of dissection is up towards the skull base so that one reaches the periosteum as early as possible. So that's the few fibers of orbicularis that is being incised. And you can see the septum. Once the septum is identified, you can see that my left hand is pulling the skin towards the skull base. And as I do that, I can feel the orbital roof. Laterally, I'm careful about not to go too laterally because as we know from the anatomy that the facial fibers may be located over here. So that is what you are already starting to see the skull base over here. That's the keyhole that is being exposed. And throughout, there is no static retractions. There is a dynamic retraction that happening for the skin as well. And this is the craniotomy size that's being measured about 2.5 to 3 centimeters. That is what we calculated on the pre-op measurements. And I will just go skip portions of this so that's the skull base exposure. The dura has been reflected back. The brains, the frontal lobe has fallen down, and patties are being utilized to access the arachnoidal regions to release some more CSF and to get the brain more lax. And as you see here, as the dissection proceeds, let me go some more. Yeah, see, directly we reach the skull base area, and what you could see is directly the tumor. And once the initial devascularization process is completed, more or less partially, then an initial decompression is done. I must tell you that there is no use of any significant retractors which are being used. It's a dynamic retraction only with the suction and the bipolar, and the decompression is being demonstrated over here. Again, beyond this, it's the standard microsurgical principles that are involved. And once the decompression is done, the tumor is slowly peeled inwards to allow the capsule to fall in and the plane to be developed between the brain and the tumor. This is what exactly is being done. You can see the medial wall of the tumor that is being dissected off the brain, and slowly, with gradual introduction of patties, that thing is being attempted and done here. That is the medial plane, and this is the lateral, and that is the top part of the tumor that is being delivered into the cavity. You can see that again, there is no significant retraction. It's just the dynamic retraction with the bipolar and the suction. And it's just the standard microsurgical principles that are being utilized over here. And this entire tumor is then debulked, separated from the adjacent vessels, more so posteriorly and inferiorly from the middle cerebral artery. And the tumor is delivered more or less in toto. So as you will see in this surgical demo. So this tumor was slightly going into the optic canal as well. So you can see this tumor is more or less now, this is out, its attachment with the surrounding brain, and the skull base is completely removed. Some patties are kept on the tumor, but to get the hemostasis, the last part of the tumor, which is stuck to the skull base, that is also has been removed here. Now, after that, what we do is we introduce an endoscope, and we try to visualize just the endoscopic thing. And I'll just pause it over. You could see with the introduction of endoscope, the entire area really opens up beautifully. We can see that there is optic nerve, contralaterally ipsilateral optic nerve, and there was some remnant in the tumor. And with the help of curette, that tumor is being gradually delivered and taken out. So you can see the ophthalmic artery origin over here. So the entire clonal attachment is out. This is a tumor which is completely out, and there is hardly any amount of significant prolonged brain retraction. And this was very, very satisfying to do. So post-operatively, again, a meticulous, I cannot emphasize the importance of closure in these minimally invasive approaches. And dura has to be closed watertight. If it's deficient, one needs to put fascia or artificial dural substitute. Frontal sinus has to be managed. Initially, we used to use wax, but now with the liquid bone cement which we have, we pack the bone cement, we pack the frontal sinus with the bone cement, and that does not allow, that has enabled us to maintain zero CSF leakages in these patients. And one needs to do a little bit of reconstructive surgery, because if there's a bone gap is wide, one needs to put a mesh. The frontalis and orbicularis muscles are approximated with 5-0 Vicryl. Eyelid is closed with 5-0 Ethilon. And we prescribed cold eye compresses every 4 hourly to such patients, and they are under antibiotic cover, anti-inflammatory, and standard. And we make sure that these patients are ambulated as early as possible. Now, without lumbar drain, they are ambulated 6 to 8 hours after the procedure. And that is the post-operative scan. And one can see that most of the tumor has been removed completely, thoroughly, and there's hardly any remnant over there. I'll just go to the next slide. Yeah, so that is the pre-op tumor. You can see that a post-op scan, that is about 7 days following the surgery. You could see a little bit of edema, swelling, but that's also reasonably well. And this is after 3 months, and this is after 6 months. You could see that there is nothing which is seen on the head as far as scar is concerned. Eyelid has healed beautifully. The eyebrows are symmetrical, and the lady is very happy with the overall outcomes. And being a lady, cosmesis is a very, very important psychological phenomena which they are very, very attached to. So such patients are extremely happy with overall outcomes. We apart from this, we wanted to emphasize that we did not stop ourselves from removing these small tumors. With our experience we gained from our tumor series, we wanted to cross that boundary and Of late, we have done some pretty large tumors also, and this was one of the largest, about 4.5 to 5 centimeters, a huge meningioma occupying the entire skull base in the midline, right from the olfactory groove down to the planum and tuberculum, and displacing the carotid artery and middle field artery, ACOM, A1s, and A2s. So one could argue, I mean, is there a point operating through this small hole? What benefit and everything? And however, with the experience we gained, and we learned so much, that we wanted to utilize this approach, not because we wanted to show our talent or our skills, because there was a scientific basis. And I'll show you what scientific basis was. This was a tumor, very huge, giant tumor. You can see all the vessels which are displaced and stretched out significantly, lot of peritoneal edema, mass effect. Conventionally speaking, this tumor is a contraindication for a keyhole approach. Forget about the transpalpable approach. But there are few things which we did, and I'm very thankful to my colleagues who are there with me in my presentation. We did a 3D printing of this tumor, and this is a 3D printed model of the tumor. We did a virtual craniotomy on this tumor, a simulated version, and then we did a 3D printed model. And we realized that we could access these tumors from all the angles where we visualized via the microscope. And this made us confident on going through and operating this huge giant tumor with a little bit of modification. So this is a patient. We did a transpalpable approach for this patient. This is supraorbital marking. This is supraorbital opening. We did a little medial extension. We dissected off the supraorbital nerve, we preserved it, and we extended our bony opening a little bit more medially, preserving the supraorbital nerve. And that provided us with a brilliant exposure of this tumor across the fox. We cut the fox, and we went beyond that to the opposite side, to contralateral side, and we could approach this tumor completely and remove most of it. This patient was about 74-year-old. Our goal was not to have a gross total complete resection, but to have at least 95% resection. This is post-op. This is the eyelid incision. That is the craniotomy that is done via the eyelid. This is only the small opening with which the tumor has been removed. And this is what the post-operative scan that would look like. The entire tumor is gone. It's taken only from the 2.5 to 3 centimeter corridor. The only place where we left the tumor deliberately was in the depths of the cribriform plate, where we had to maneuver significantly the dural region. We left it not because we were not able to access it, because in about 76-year-old man, we didn't want to give him any CSF leakage or anything of that sort. We are keeping the biopsy was WHO grade 1 meningothelial. This has been followed for last 2 years. Tumor size is remaining same. So we are pretty happy with this kind of a tumor excision with transpapillary approach, which remains the largest tumor ever reported in the literature. We're going to publish this. Post-operatively, the patient did extremely well. This is his photo after 1 week following the procedures. No head bandages, no drain, no pseudomeningocele, no lumbar drains, nothing. And the wound has already started to heal with any visible sign of. This is 3 months following the procedure. You could not see any scar with significant improvement in his KPS and his performance and functional level. We have again extended our approach to aneurysms for these patients, for some patients. And this is one small aneurysm that is located in the IC bifurcation, unruptured. This is a schematic diagram, and you could see the ICA. This is a bifurcation. This is the MC vessel. This is the aneurysm neck. This is the A1 going this side, and that's a dissection being done. So that is following clipping. I'm sorry for this video, the focus is slightly off, but this is the M1, the middle cerebral artery, which is arising M1. That is the A1 from there, and the aneurysm that is being clipped via a small window. So this is the aneurysm clipping. Recently, I would like to introduce you to our new extension of this approach for insular gliomas. Now we have devised, or probably say we have fashioned an approach called as keyhole transbasal transisthmic approach to insular gliomas, which challenges the convention notion of approaching insular gliomas via only the transsylvian approach or transauricular approach. It has got two basically forms. One is transbasal component and a transfrontal isthmus. This is a minimally invasive approach because it involves only a small, about 2.5 to 3 centimeters with no significant brain interaction, no amount of sylvian dissection is required, and more or less it's straight inline trajectory. And it also questions, should we be really doing this patient awake? Should we be really using monitoring this patient or so? So this is just a schematic video, 3D video, which I have made to illustrate that point. So this is the insular region. The tumors are located within the insula. So we approach the tumor transbasally via the supraorbital corridor, just in front of the frontal auricular region in the basiorbital region, and then enter the insula over there. And then, as you see, try to get to the plane. Now I've shifted the model and this is the insula as when you look from the basal point of view, and then you try to get into the insular tumor, staying lateral to the frontal horn of the lateral ventricle and to the caudate nucleus. And that area that is being demonstrated in the blue arrow is the area called as isthmus, which is lateral to the frontal horn of the lateral ventricle, and that guides us as a highway, as a pathway to the insular region. That's the isthmus. And so that's why it's called as transfrontal, basically frontal supraorbital, and going into the isthmus, transisthmic approach. Yeah. So as again illustrated in this cadaveric specimen, so this is the insular area. So we come transbasal from the base into the frontal auricular area, then get into the isthmus area, which is lateral to the frontal horn, and then you get into the insula. So this is ideal approach, I think suitable approach probably for lesions located in zone 1 and zone maybe 3 location. So this, however, needs to be seen in cases when we do more and more in future. This again to show you this approach. This is the insula, and this is the trajectory you are taking. You're going into the auricular region basally. However, entering basally, you're not entering laterally. And then you're entering into isthmus. Isthmus by nature is widened in insular glioma. So those tumors located in the anterior portion of the insula, auriculoinsular gliomas, they are probably ideally suited for this tumor. And we exploited this knowledge and our knowledge about minimally invasive approach to remove an auriculoinsular tumor via this, which remains to be first in the neurosurgical literature in the world. As I talk, we are again in the process of publishing this. So this is the insular auricular glioma with the dominant side. And this is a representative snapshots of the intraoperative findings. So that what we see over here is I would say suborbital region of the frontal base. And this is the ventricle, an area lateral to the ventricle. We stay around, it gives you a passage to the isthmus, and beyond that would be the auricular and the circular cistern. And that gives a very nice passage to the insular region. So that is the pre-op scan. And this is a post-op CT scan. The biopsy was WHO grade oligodendroglioma. So these are some of the cosmetic outcomes which have been observed following transpalpebral approaches and supraorbital approaches with extremely good outcomes. As far as experience is concerned, literature-wise, all such cases which have been done via this approach, they have shown good cosmetic outcomes with achievement of primary outcomes in all the cases as experienced in our group also. So did we have any approach-related trauma in our series? Yes, we had a patient with probably one frontal contusion, but however, the patient was on some blood thinner. But however, surgical objectives reached in 100%. We never backed out or we changed our surgical plan in our patients. Cosmetic outcomes was most of the patients, or rather all of the patients, were nearly happy with 98 to 100% of satisfaction rate. Our stay in the hospital for such patients has been reducing progressively, and it all depends on the pre-morbidity and the lesion. For an uncomplicated surgery like a simple meningioma or simple frontal interaxial tumor, we discharged this patient 36 hours following the surgery. We had one patient with meningitis, one with subdural hygroma, and one continued to have a neuropathic pain, which required pain intervention management. We didn't have any patient with CSF leakage. There was no patient required a prolonged bed rest, no patient with pseudomeningocele, and no patient with any permanent facial weakness. But I must admit that this data is preliminary. My experience is not that huge. We are still evolving in the process to learn. But these are the initial trends which I've been noticing, and that's what been found and described in the literature. as we see in this article. There have been a meta-analysis compressing conventional versus minimally keyhole approaches, and 3 things have been found to be significant. That is post-operative duration of stay, cosmetic outcome, and shorter operative time. These are the things which have been achieved with the cosmetic outcome. So with our limited data, with less number of patients, we can say that we have been able to do a reasonable job with a very good surgical efficacy and very good cosmetic outcome with reduced duration of stay. And definitely for selected lesions, we are, as our experience is becoming more and more, our indications are all expanding, and depending on our size, location, extent, and we are definitely looking forward to have a collaborative work with people from skull-based surgery, from ENT, from ophthalmology, from radiation oncology, to give the best for our patients. Concluding, as this great person said, the eyes are windows to your soul. Now we say the eyelids are windows to the skull base. Thank you very much for your kind attention and patience. Thank you. Thank you very much. I'll be very happy to discuss. I'll be very, very interested to know what do you think about this novel approach to insula, and what has been your general philosophy of management and treatment. Thank you very much.
Thank you
Thank you,
very
Dr.
much,
Sakar,
Dr.
for great
Rishikesh.
presentation.
Let me just give one comment. Dr. Rishikesh is not only my colleague, but very good friend. And I was lucky to be in the department in Apollo Cancer Hospital. And I witnessed the collaboration work, teamwork with the people and with Dr. Vignesh Sai, who is also my good friend. This is brilliant presentation and brilliant, expression of your experience, and also brilliant anatomy with 3D modeling. So thank you very much. Whoever has questions and comments, please.
No question, no comments?
Maybe questions and comments will come later. Okay, whoever has, please, you can put your questions to the chat.
Okay. So next speaker, Emrah Chowtikchi, consultant neurosurgeon at Gazi University, Faculty of Medicine, Department of Neurosurgery, member of Turkish Neurosurgical Society, member of IANS, Ankara, Turkey. Name of topic, transorbital neuroendoscopic surgery for treatment of sphenoid wing meningiomas extending to the cavernous sinus, clinical implication and technical illustration.
Hello, everyone. Good to see you. So, hello from Ankara. So today I will speak about transorbital neuroendoscopy on sphenoid wing meningiomas extending to the cavernous sinus. So it's a little specific topic. I'll be trying to be brief. So also, I'm a strong believer of the attention span of many people are just 20-25 people. So I will try to be quite brief. So first of all, I will try to explain what's transorbital neuroendoscopy, and what we are trying to do, the simple indications and other things. So first of all, this paper became our paper, which we focused completely on 2018. What is transorbital approach and what are they doing? Because we already started this date. We were doing endoscopic skull-based surgery with our team, with Dr. Melih Şahin from ENT, and we already did not only the sagittal plane, but also we already extended our approaches to the lateral plane. So in this paper, there are 4 different defined corridors, which are the lateral corridor to the middle cranial fossa, a lateral corridor to the anterior cranial fossa, and combined and medial corridor to the other regions. So we try to focus. We managed our approach for lateral corridor to the middle cranial fossa. So orbit itself is a potential way of approach, and as you know, I don't know how many of you guys are working on the both lateral, middle, and superior sides of the orbit. The bone itself is not as thick as we used to in transcranial approaches. So what we do here, basically, we are doing an transorbital approach, and as you see on here, painted with green, you will see that if we want to go to the posterior part of the sphenate wing, that's drilling the green part is more than enough. So we in our own approach, in our own indications, we didn't decide to extend our drilling through the optic canal or medial parts in order to avoid complications. So what we do is drilling the sphenate wing, the greater sphenate wing, and first of all checking the temporalis muscle, then checking the dura. So what we do here is a superior eyelid incision in which we will see the bony structures, and then a simple retraction of the both globe and the orbit. It will provide us a huge corridor. So some people are asking us, oh, is it that dangerous to retract the globe, and isn't it, you know, will not it cause some problems? So what we do here is creating a corridor to the middle cranial fossa, and our aim is operating the patients with meningiomas, with sphenate wing meningiomas extending to the cavernous sinus. So both in our paper and in our presentations, people are asking us why you limited your indications in this. So first of all, in Ankara, in Gazi University, Department of Neurosurgery, we are the oldest ongoing gamma knife center in the country. So we have performed more than 10,000 gamma knife applications so far till 2004. There are a lot of patients coming to our center for residual or for some recurrence, this kind of meningiomas. So as far as we know, you cannot completely resect cavernous sinus meningiomas. So here's the thing, okay? If somebody says, oh, okay, I resected a cavernous sinus meningioma completely. No, come on, it's not a reality, okay? Yeah, I mean, it could be a reality, but the thing is, what was the morbidities, right? So our aim is giving the perfect treatment to the patient, but without no morbidity and no mortality. So that's the key. So if we already know with a lot of recent papers that total resection of cavernous sinus tumors is not achieved, you know, it's not logical. So why don't we only resect the sphenate wing part and leave the cavernous sinus part and send the patient to the radiosurgery? So the positioning is like it's forehands technique, and there should be a team who already did a lot of surgeries. But the thing is, what we should do, first of all team must be experienced in endoscopic skull-based surgery. They should have done at least 500 cases. And as far as I said, we are working with ENT and neurosurgery with all the cases. And by saying all the cases, I'm not mentioning only neurosurgical cases. I'm also saying the cases like like adenoid cystic carcinoma, inverted papilloma, which I say sinonasal malignancies. So the team should know each other perfectly, how to position the drill, how to position the telescope, how to position the suction. They should know each other very well. So this is our first case. So why did we choose that case? This case has underwent many times with a siphonoid wing meningioma, already lost the vision. So that was the perfect case to start. So as you will see on the left side, yeah, on the right side also the post-op films. So see the craniotomy on the CT scans. So first of all, after local anesthetic application, we're opening the superior eyelid. So you see, we detect the bone. So the key is not destroying the orbital fascia. So it's very important. So why it's important? Because, you know, I mean, as you know, there are people who are previously operated like endonasal approaches. So everybody knows if you go into the orbit, the fat tissue will expand through you. So it's not a good thing. So now we are drilling a little, but this should be a little. Why a little? Because if you drill this part of the bone, the frontal bone, you will open the frontal sinus. That is something which we don't want. Now, the first thing we are trying to do is detecting the temporalis muscle. So as you see on the lateral, we start to see something, but we are continuing drilling. And as you know, yeah, you see on the right, the muscle, on the left, the dura. So now with the Kerrison ronger, we are expanding our craniotomy. Yes, this is a craniotomy, by the way. So what we are doing is removing the bony structures. So this is also crucial and beneficial because, as you know, this kind of meningiomas generally leads a secondary problem, which is the hyperossification of the siphonoid bone. So also by drilling the bone from anterior to posterior, we are helping a little for the proptosis which caused by the hyperostosis. So some patients are asking us, oh, will all our cosmetic problems be okay? The answer is no, because most of these tumors are entering into the orbit too, invading the orbital muscles. They already disrupt the both venous system and the lymphatic system of the orbit. So the cosmetic problems will not be completely gone, but there's a good outcome. So what we do here is excising the tumor, using sometimes retractors, sometimes ring carets. And as I say, this is our first case. So, and also this is our first and only case with a complication. In that case, you know, as a skull-based surgeon, we thought the thing that we worry most is the vascular injury, and the thing we worry the second is the CSF leak. So in order to prevent the CSF leak, we applied and lumbar drainage for this patient. And postoperatively, also we put a Penrose drain in order to prevent the intraorbital hemorrhage. So following both Penrose drain and lumbar drainage CSF drain, this patient has experienced a pneumocephalus, which became a good experience for us because after that patient, after that case, which is our first case, we never applied lumbar drainage again because that we see that the orbit itself is a good flap, and it closes all the both the bony defect and the dural defect very well. So these are one of the patients that we gained, you know, in sometimes some experience. So as you see here, the patient has both some cosmetic problems, intraorbital tumor, and hyperossification, and an intradural tumor. So on the left top, you will see the surgical time. So you will understand how long it will take to complete the surgery. So again, we are doing the same thing. We are trying to find the bone first. But this time we are going a little faster. We already has experience on the field. So you see, I'm pressing the temporalis muscle here. Yeah, you can see. So we understand now that's the temporalis muscle. Okay, we are going lateral to the medial. So the key is doing this approach always from lateral to medial. Never go to the medial first. First, detect the muscle, and then start drilling the siphonoid bone. So you see, we are extending our craniotomy. We already approached to the tumor, in fact, but we are not starting excision. We are just trying to be sure where our limits are. So as we learned from our previous surgeries, we are, as you see, we are coagulating the medial part because now we know from our experience the dural feeders are coming from medial to lateral, not lateral to medial on this side of siphonoid bone. And now we made an incision, and now we are using an ultrasonic dissector, a cavitron, in order to dissect the tumor. Also, as you will see, as experience increases, the surgical field changes. Now, in previous video, the surgical field was much more red. Now we are working in a much more clear surgical field. So how we close? We apply Surgifoam and then Codman synthetic dura, and again a Surgifoam, and that's it. That's all we apply. So our clinical results are, in our paper, we published our results of 32 patients, and preoperative visual deficit patients were 14, and new onset postoperative visual deficit we didn't see in any patients. And as I said, we have only one postoperative complication, and mean hospital stays like this. So in the first 5 cases, it was 2 days, but after the first 5 cases, we only hospitalized patients just 1 night. So this is also something good because, as you know, if you operate a sphenoid wing meningioma even with a small craniotomy, the patient will stay at a minimum of 2 or 3 nights at the hospital, and we have 0 CSF leak. So this month, our clinical results and our technique was published on Neurosurgical Focus journal, and happily they also accepted us to the cover of the journal. So this is really good for our research team. This is Gökberk and Gardashan, who works both in the lab and for managing the illustrations and the paper. They really worked hard. So they were in our research team. Gökberk was also our resident. Now both of them are consultant neurosurgeons, and also we really thank Jurajanas Medical Arts, because both the illustrations you saw in this presentation and also the cover art and the illustrations in the neurosurgical focus paper was performed by them. So first of all, as I said, I'm not doing all of this alone, okay? So Melih Şahin, who is an associate professor in the Department of ENT in our hospital, is very crucial for performing this kind of approaches. So one could say, oh, I can do everything, I can do everything. I mean, you cannot do everything, you cannot know everything, let's be honest, okay? So without Melih performing a eye lead approach, which would require at least some knowledge of plastic surgery, aesthetic surgery, I don't have that education. So this is very crucial. And also this is very crucial to understand that teamwork is very important, because as you see in this graph, as a neurosurgeon, I mean, pituitary adenomas could be the only patients, maybe some craniopharyngiomas and meningiomas and chordomas. But as you see, we are already operating sinonasal malignancies, sinonasal pathologies, and transorbital. As you see, we already did one more. And Vidian schwannomas and other pathologies like even mucosals. So this is very important. We are getting all the cases together. Even sometimes I attend some cases which are not neurosurgical cases, a simple ENT case, but no, it's a endoscopic skull base case. So I should be there, he should be there, we should attend all the cases together. That's the power of being team. So for any young neurosurgeon who is listening to this presentation, my recommendation is, I mean, from my point of view, the era of single superstars, you know, like people we know previously, who works alone, like they are the celebrities, is over. So in all over the world, there are lots of neurosurgeons. So you should first of all specialize on particular areas. Also, you should do some kind of teamwork in order to increase the quality of surgery, quality of service that you are doing. So thank you for everything.
Thank you, Dr. Emre, for excellent slides, for great illustrations. Maybe moderators, speakers, or panelists have questions or comments.
I just want to add a comment over here. Am I audible?
Okay.
Yeah. Dr. Emra, thank you for your wonderful presentation. It is really a eye-opening approach, actually. It's a very direct and thorough approach to the middle cranial fossa anti-relocated lesions. And it definitely paves the way for us also to move in that direction from supraorbital to intraorbital compartment. I think I think we can make that change now confidently after looking at your presentation. But as you said that it requires definitely a teamwork. And that's what we also believe in, that one person cannot claim entire skills to himself or herself. One has to collaborate in these days. And definitely there's a time to join hands together and try to tame these complex problems in skull base areas together. So I think with your presentation, it's very clear that in the coming days ahead, these complex pathologies, mainly those are small and located in the anterior skull base, so in the middle cranial fossa region toward the cavernous sinus, can be dealt very effectively. I think this is one more addition to our armamentarium, in addition to radiosurgery and other things, to tackle tumors located in this area. I just wanted to understand from you, however, number one is that would you always require, do you use neuronavigation always for such tumors, or there are fixed landmarks, or because low resources setting with limited things available for surgeons, can this be done? That's something which I want to ask.
So here's the thing. First of all, if you ask, are you using neuronavigation for all these cases? My answer is yes. But if you ask why, it's first of all, it's for prevention, any problems, you know, medical legal, because also the things are in the same like in the United States, in Turkey. So we should do all the steps to prevent us from any problems which would, you know, cause some medical legal problems. So but if you ask me, do you need, the answer is no, because there are landmarks, there are sutures, because you can see that you even can see that even on the real surgery, you can understand where is sphenoid wing, where it goes to the frontal and where it goes to the lateral. So most important landmark is, surprisingly, the temporalis muscle. Once you find the temporalis muscle and you go from lateral to medial to the temporalis muscle, that minimizes any onset of any complication, including vascular complications. But the thing is, for new beginners, I strongly recommend the neuronavigation. So here's the thing: we are in Gazi University. So what we do for this kind of patients, we in our operating room, we use neuronavigation. We not only use neuronavigation, we also use neuromonitorization, including the optic nerve. Following the surgery, without extubation, we took the patients to the intraoperative MRI. Also, we have intraoperative MRI papers on endoscopic skull-base surgery to check if there's any residual tumor, or to see if there's any residual tumor, will it be worth of resecting, or it's okay, you know, we decrease the tumor volume in order to apply for a safe radiosurgery. So if you ask, is neuronavigation is something like it should be, my answer is no. If you know the landmarks, if you know the neuroanatomy, you don't need neuronavigation. So as a neurosurgeon, during my residency, I didn't had any endoscopic skull base surgery experience during my residency. So that's why I had to go to United States to complete a surgical neuroanatomy fellowship on skull base. So following that education, that's the way I could understand what are the bony landmarks and what are the limitations, what is anterior skull base. So these are the ways to understand the neuroanatomy.
Yeah, just to add on that, because I also believe in neuronavigation and using all the technology possible. In fact, we had an interop CT scanner and we use it routinely. The reason I asked, because a large majority of neurosurgeons across the globe, they do not have an access to neuronavigation. They are just based on the anatomical things. So one suggestion I can give it to them is they can use a virtual simulator like Osirix X or anything is available free online, or they can also utilize 3D printing to do a simulation surgery before and then go on to the operation theater. That will really reduce the learning curve significantly. This is one thing I can add on from my side. Thank you.
Yeah,
Thank you.
By the way, I will add something about that. So during my fellowship, also I didn't had any transorbital neuroendoscopy experience. So when we decided to start transorbital neuroendoscopy surgeries in our center, first for 6 months, we studied on cadavers in here. So after that, after understanding the neuroanatomy, then we started.
Yeah.
Okay, so we also have a question from the chat. Dr. Rizki Mezikri asked a question. Is there a certain case in which you deem this approach unsuitable?
Unsuitable.
Unsuitable, sorry.
Can you repeat again, or can I see?
Yes, is there a certain case in which you deem this approach is unsuitable? So which diagnosis or for which type of tumors you will not proceed with current approach?
So the thing is, the transorbital approach for siphonoid meningiomas is just a newly defined technique for this kind of pathologies. So in order to say something scientific, there should be an evidence-based paper and enough evidence on the literature. But from our point of view, what we are trying to understand is if tumor is too much extending to the cavernous sinus and also to the anterior clinic process, which means the tumor mass is mostly on the medial part, but on the not lateral part, then we are avoiding not, you know, we don't do this approach.
Thank you. If anyone from panelists have questions,
I think Aldo
Professor
has a question.
Spallone, Professor
Yeah.
Spallone, yes, could you unmute yourself? Okay.
Go ahead, Aldo.
Can you hear me now?
Yes, we can
Yes.
hear you.
Oh, yeah, because I'm fighting with my computer, I'm sorry, and at least I cannot show myself, but I'm not so beautiful as the rest of the panelists, so better so. I was impressed once again by the first presentation of the Russian colleague, but also I have to congratulate to the two ones who exhibited themselves afterward. And this made clear one point, that there is a space for any kind of philosophy. And nobody can get, unless he works on very privileged environments, like, for example, the Beijing Neurosurgical or the Burdenko Neurosurgical Institute, where there are over to 10,000 cases a year, to provide straight guidelines. So you are always guided by your own experience, which is logical. I had, for example, I was pretty much impressed by the experience reported by the colleague of Apollo Hospital, and I must say that if I have the idea of the Indian neurosurgery, I think about Atul Goel, whom I know for a long time, and he always stressed to be a solo surgeon. I understand that the future is a team-wise work, and this is very good. I was I had some little education in the US where the ENT did the approach, the neurosurgeon did the rest of the job. This is fixed legally. The ENT cannot incise the dura, and the neurosurgeon is obliged to have colleague with higher experience on dealing with drilling. And once again, I had the impression that sometimes the idea, the basic strategic idea was different. When I was leading the skull-based surgery group, I didn't have any privilege like this in my country, for example. I had it in Cuba. I imposed the philosophy of having the same team for the opening and for the intradural work. because the strategy idea had to be the same. And this resulted in splitting as a routine. It was done before the operation in 2 different days. This was a suggestion I got from the United States at that time. Now we are having another technical trick which reduces the operating time, which is endoscopy, and the endoscopy-like modification of the traditional skull-based surgery, which is, for example, what the Indian colleague showed. Very, very interesting. What to say? Everybody, once again, believes better on himself and his experience. And that a large amount of the different solutions from the same, from the individual problem. I have just a technical remark to make of the people who use limited approaches. If you have to deal with something very difficult in the deep of your field, it is extremely difficult to deal it properly unless we have several angle views, which means that you have to maybe think about enlarging the approach. This can be resolved with other means, a larger use of parasurgical adjuncts such as radiotherapy, for example. There is nothing bad. Long-term results show that this is a good way, and this can be the future.
Thank you very much, Professor Spallone, for your comment. Maybe anyone else has comments? Dr. Takashi Kon, Dr. Mario, whoever is here.
Well, I fully agree with what Aldo has just said, and it resonates very well with my clinical practice. On Tuesday next week, we will be doing a diploid tumor with extension to the orbital roof. It will be 3 surgeons, me, and other skull-based colleagues, and the plastic surgeon and the ENT surgeon operating all together. So teamwork is certainly the future of our surgical practice, particularly because lesions might be very extensive. Length of operations might be, well above 10 or 15 hours. So certainly sharing the tasks is important. However, having the very same anatomical view, geometry of the lesion matters. And therefore, the comments that were made before on surgical planning, virtual surgery, use of 3D printing, we are certainly all on board with all those steps.
Thank you. So if we don't have any comments or questions, I think we can finish today's webinar. I want to thank everyone for joining today, for giving nice presentations. And I think today's webinar was very impressive. And next webinar. Yes, sir.
If I can add, so basically it's now afternoon in Europe, evening in Asia, and early morning in the US. This grand round is demonstrated to really be more and more a global gathering for presentation of very nice surgical technique from our colleagues. I just wanted to say that there is very good news for us. Basically the summary and analysis of all the data about presentation has been accepted for oral presentation at the EANS in Sofia. So we will have the opportunity to showcase the good work that we have done here for the Russia Grand Round Neurosurgery. Thank you very much.
Great, good news. Thank you, Dr. Mario. I want to announce our next webinar, which is going to be 28th of May. We are going to talk about trauma in neurosurgery. So whoever wants to be a speaker, please join, and the link we will be sending next month.
Okay, very good. Very good. Okay, thank you, Nagisa, for putting all this together. And thanks for all the speakers. And we'll see you in a couple of weeks.
Thank you so much.
Thank you.
Bye-bye.
Thank you guys.
Thank
Stick
you.
around.
See you again.
Stick around.
Thank you
Thank
to
you, Ross.
everybody. Yeah.